Hello, my name is Jeff Brettler. I'm an internist and hypertension specialist, and I help co-lead the hypertension program in Kaiser Permanente in Southern California. I'm also a consultant for the Pan American Health Organization, and it's a pleasure today to talk to you about how key drivers can improve hypertension control. So my agenda for the next 30 minutes is as follows. Would like to give a little bit of background, talk specifically about the gap in blood pressure control in the region of the Americas where we work, and then get into detail about what key drivers are. Talk about their importance, how we might think about implementing them, move towards some clinical and implementation outcomes, how do we measure our performance with key drivers, and then finish up with some challenges and lessons that we've learned over the last 1 to 2 years. So this is the background for why this work is so important. Systolic blood pressure continues to be the most important and modifiable risk factor for early heart disease, both globally and in the region of the Americas. And we estimate that cardiovascular disease accounts for 2 million deaths annually in this region. And what we see here are the traditional hypertension cascades in women on top and men on bottom. Starting with the prevalence of hypertension, you can see 28% in women and 43% in men. But then the traditional cascade looking at how many patients are aware of their condition, how many patients are on treatment, and how many are in control. And the bottom line is that control in the region of the Americas is very suboptimal, 35% in women and 23% in men. So whatever we've been doing, we think we need to intensify and perhaps change direction. And it's not just blood pressure control itself, but also the burden of cardiovascular disease that becomes affected by this. So this is a nice study out of Journal of Clinical Hypertension a couple of years ago, where they looked at cardiovascular disease disability-adjusted life years. And as expected, we see a dramatic decline over the last 3 decades in cardiovascular disease burden. But what you notice on the right-hand part of this graph is a very concerning trend. And that downward slope really has begun to flatten and perhaps begin to increase. And when you look at the detail of this study, what we actually find is in 11 countries in the Americas, there's stagnation of this downward trend in cardiovascular disease burden, and in fact, in many cases, in increase. So very concerning trend. But we know that high blood pressure control can be achieved. So here are 2 very well-quoted studies in the literature. On the right is the Canadian experience, probably the best experience from a national perspective, in large part due to the Canadian Hypertension Educational Program, where they achieved dramatic success over the course of a couple of decades with a 50% improvement in control rate. And as you can see with the small graphs to the right, all of the resultant cardiovascular disease outcomes that you would expect to fall with an improvement in blood pressure control, stroke, heart failure, acute myocardial infarction, have fallen dramatically as well. So great experience from the national perspective. From a health system perspective, we're showing the experience in Kaiser Permanente in Southern California on the left. And what you can see here is dramatic improvement as well over the first decade in 2000, with an improvement in hypertension control from 50 to 85%, which has been sustained. And we'll talk in more detail about the Kaiser Permanente experience momentarily. So what are the characteristics of high-performing health systems? Why do these systems perform well in achieving blood pressure control? And we think that in addition to focusing on outcome measures, which is hypertension control, they do a number of additional things as well. So number 1, they identify the key drivers of that improvement in blood pressure control. They translate those key drivers into process measures, and then they provide performance feedback to frontline clinicians and clinics. And we'll go over each of these steps in more detail. So taking a step back, let's talk more generally about quality measures. And according to the Donabidian healthcare quality model, there are 3 classic types of quality measures: structure, process, and outcome. And traditionally, we spend our time talking about outcome measures, which in the case of blood pressure is control of blood pressure and coverage, But what we don't spend as much time on are process measures. And those are the specific care delivery elements that really lead to the improvement in blood pressure control. And we call those key drivers as well. So the intervention is the key driver, and the measurement of that intervention is a process measure. And what's nice about process measures is that they are directly under the control of the provider or clinic. So it's very powerful to work on these at the level of the healthcare system or clinic because it's something that the clinic can actually control. The other important temporal event that's occurred very recently is now a new and excellent and comprehensive hypertension guideline from the World Health Organization. So for the first time in 20 years, in 2021, we now have very well established and guideline-based recommendations for a number of important key drivers as well. When should we start blood pressure medication? What should the goal of blood pressure treatment be? The importance of cardiovascular disease risk assessment, which medications to use, the importance of fixed dose combination treatment, how frequently should we bring patients back, and the importance of treatment by non-physician professionals. So a lot of guidance in specific areas that previously we did not have recommendations. So let's get into some of the evidence about key drivers. And I'm going to start with giving some data and some evidence around specific key drivers, and then we'll move towards the more systematic approach to the use of key drivers. So let's look at some specific key drivers. So let's start with a specific driver accurate blood pressure measurement. And in this case, the recommendation that the blood pressure should be repeated when the initial blood pressure is elevated. We know that a single office blood pressure measurement is not reliable. In fact, about 34% of initially elevated blood pressures will normalize when it's rechecked. Yet this is done very infrequently. Only about 23% of the time does this occur in common practice, despite the fact that it's supported by multiple guidelines. How about the driver as standardized treatment protocol? In this case, use of an established protocol with fixed dose combination pill. Well, the evidence for this driver is very strong. We know that most patients require more than one medication, and we know that fixed dose combination pills improve adherence, they improve control, and because of that, they decrease the length of time needed to achieve control. Yet when we look at the use of fixed dose combination pills, it only occurs about 1 in 5 patients in the United States, again, despite widespread support by multiple guidelines. Now, when we look at the Kaiser Permanente system in Southern California, we see some further evidence of the importance of combination pill use. In this case, you can see a dramatic improvement in use of fixed dose combination pill, and improvement in blood pressure control follows. So very important, at least observational evidence. Now, how about the driver and treatment intensification? This is also critically important. And in a recent study of many US health systems, we found that systolic blood pressure decreased dramatically when a new blood pressure was added. Yet we know that treatment intensification occurs very infrequently in the United States. This large study using pharmacy data shows that over the course of about 10 years, treatment intensification in the US was not only low, averaging about 15%, but in fact was stagnant and perhaps even decreasing over time. Now, how about team-based care, another important driver, and specifically the recommendation that medication titration should be done by a non-physician. Again, lots of evidence. We'll show you that team-based care with titration by a non-physician may be the most effective implementation strategy. And we know there's a global shortage of physicians to treat hypertension. So let's start with looking at the data for why this intervention may be so powerful. This was a meta-analysis published a couple of years ago in Annals of Internal Medicine, looking at different implementation strategies to improve blood pressure control. And what we see here on top for both systolic and diastolic is that team-based care with titration by a non-physician is the most effective strategy to improve blood pressure control, and in fact, outperforms team-based care with titration by a physician. So very effective intervention. It has the highest level of support from the American College of Cardiology and the American Heart Association, and the WHO in their most recent guideline now also supports medication titration by a non-physician, as long as certain commonsensical conditions are met, as shown on this slide here. Now, the other important aspect to this is that we just do not have enough physicians to treat hypertension globally. So this was a study out of hypertension about a year ago, which shows the shortage of physicians to treat hypertension. So you can see even with one visit a year, which most of our patients will of course need more, depending upon the income level of the associated country, there's a dramatic shortage of physicians needed. And then as you begin to move towards needing more blood pressure visits per year, even in higher resource settings, there's a dramatic shortage of physicians. So we need to use non-physicians to treat blood pressure. Now, how about the driver of encounter interval? How quickly do you bring patients back with an elevated blood pressure? And there's a lot of good data that shows the faster the better. This was a retrospective study done in Massachusetts, which showed a dividing line, a separation at less than 1 month. So that if you begin to bring patients back in more frequently than 1 month, you can achieve blood pressure control as quickly as a couple of months. But as that interval begins to increase, it may take up to 1 year to achieve control. So very important driver. And this not only is important for blood pressure control, it's important for cardiovascular disease outcomes as well. And this was shown nicely in a retrospective study out of the UK, which showed a dividing line here of about 1.5 months. In other words, if you delayed bringing patients back in and intensifying their treatment more than 1.5 months, you begin to see a signal in increased cardiovascular disease outcomes. So very important finding. Now, how about the driver of medication refill interval? A very basic and simple driver to implement. And when we look at 30 versus 90-day refill supplies, multiple studies show that adherence improves as the refill interval increases as well. So very straightforward driver. Now, how about performance feedback and data? I want to show you one specific example from my system here, which illustrates the importance of specificity of data. So here we're looking at treatment intensity rates by medical center. These are large healthcare systems, about 500,000 patients. And what you see here is not a lot of variation between medical center, with treatment intensification rates in the 30 to 40%. But when you break this data down by individual physician, you begin to see dramatic variation between 5 and almost 70%. So this becomes very powerful and very actionable data when you take it back to your individual physicians along with their control rate. Now they have something that they can specifically do to improve their blood pressure control. Now, how about looking at process measures and key drivers from the system perspective? I think this has been shown nicely now in a number of studies over the last couple of years. We'll start with this study from 25 US academic health systems, and you begin to see the language here that's used as well, process metrics or process measures. And what we see here are a couple of important findings. Number one is the delineation or identification of what are considered key drivers in the literature, and I've highlighted a few of them here. But we also see the opportunity to improve performance because the baseline performance on these key drivers is so suboptimal. So we mentioned confirmatory repeat blood pressure when the initial is elevated. You can see that only occurs 23% of the time. Treatment intensification only about 12% of the time. And importantly, what this study also showed is it provides us a roadmap to improve healthcare disparities specific to hypertension control. So before we could potentially measure specific rates in different racial and ethnic groups, but we didn't know why those groups were not doing as well. When you begin to look at process measures by race and ethnicity, you can get very specific and actionable data that can then can allow you to begin to address healthcare disparities. Now, this was a nice simulation study that we like to talk about, which looked at the goal of achieving 80% hypertension control in the United States. And they looked at 3 specific key drivers that I've highlighted here in blue: medication adherence, treatment intensification, and return visit interval when that initial blood pressure is elevated. Under usual care, you see what happens across the country, very suboptimal performance. Medication adherence about half the time, treatment intensification occurs only about 13% of the time, and we're only bringing patients back in about every 14 weeks, which is quite lengthy. You can see the best observed values in the middle column, which really perform much, much better. And then what this study did is they put these 3 different levers into a simulation model, and they adjusted them to see how to achieve 80%. And here were the findings. If you kept doing the same thing, you were only going to achieve a control rate of 46% of those patients who were initially under control. So very sub-ideal. But you could achieve 80% control rate over 4 years with the following. Increase your medication adherence to 70%, increase your treatment intensification to 30%, and bring patients back in at least every 4 weeks. And of all of these levers, this study found that treatment intensification probably had the most significant impact on achieving blood pressure control. And in fact, if you did nothing else but improved your treatment intensification to about 60%, you could achieve a hypertension control rate of 80%. So very nice model of how intervening with specific key drivers can impact your hypertension control rate. Now let's get back to the Kaiser Permanente system. This is data out of Northern California. What you see here in the early 2000s is that Kaiser actually was behind the national average, and then in 2005 had a very rapid improvement in blood pressure control rates to the 90%. So the question asked is what happened in 2005? And there were 2 things that we think drove this dramatic improvement. The first was combination therapy with lisinopril hydrochlorothiazide in a single fixed dose combination pill became the first step of the national Kaiser Permanente algorithm. And we've already shown you the data on the right, which shows the correlation of use of the fixed dose combination pill with an improvement in blood pressure control. But the other key driver that was implemented in 2005 was the widespread implementation of follow-up BP checks in 2 to 4 weeks, not with the physician, as was historically done, but with a medical assistant or LVN. So this uncoupled the physician from the follow-up blood pressure check, led to a much increased access of appointments and an improvement in blood pressure control. Now, the question has been asked, can we translate these key drivers, including what's been found in the Kaiser system, to other healthcare systems? And we think the answer is an unequivocal yes, and this was shown nicely in a safety net system out of the San Francisco Federally Qualified Health System network. And what they did essentially was they looked at 5 specific key drivers. In this case, the study calls them program components, but they're in essence key drivers or process measures. The use of an evidence-based treatment protocol, blood pressure check visits led by a non-physician, standardization of blood pressure measurement protocol, a hypertension patient registry, and performance feedback and reports to frontline physicians. And what they did is they took these 5 key drivers and they modified them slightly and integrated them into the San Francisco safety net system. And what they found beautifully over the course of about a year and a half in a fairly large study of over 16,000 patients was a dramatic improvement in blood pressure control. And in fact, this occurred across all racial and ethnic groups, and you can see a dramatic narrowing of the disparity gap. So very nice evidence that implementation of key drivers is a very, very effective strategy. So what was the next step in thinking about key drivers and how we might put this all together? And what we did was we formed an innovation group with Hearts. And the innovation group came from multiple disciplines, including nursing, primary care, and specialists. And they had participants from the initiating 12 country and Hearts, as shown on this slide. This group met every 2 weeks over the course of a year, and they really studied multiple best practices out there in the United States, including Kaiser, but multiple other systems as well. We made heavy use of the hypertension control change package from the CDC, which is a wonderful compendium of best practices culled from around the country. And then what we did was we decided based upon the evidence, what were the critical key drivers that were feasible to implement and how we should put them all together. And we published this data in Lancet Regional Health Americas in 2022. And this is a summary slide of the key drivers identified. So what you see here on the left are the 5 domains of blood pressure strategies. In the middle are the key drivers, which we have identified: blood pressure measurement accuracy, cardiovascular disease risk assessment, standardization of treatment protocol, treatment intensification, continuity of care, team-based care, medication refill frequency, and a system for performance evaluation with feedback. This all gets put together into a comprehensive scorecard as shown on this slide here. So you see the 8 specific key drivers on the left, and associated with those key drivers are 17 specific measurable recommendations listed here. Each recommendation has a specific goal associated with it and a point system attached as well. All of these scores get rolled up into one consolidated index, which we call the Heart's Process Maturity Index. And the beauty of this is the one number allows us to track health systems over time, but we can also compare and contrast health systems. So which systems are doing well and perhaps have best practices that we can replicate, and which systems or clinics may need additional areas of focus. Now, those are process measures. We still need to measure outcome measures, which specifically are coverage and control of hypertensive patients. So Hearts has also created a performance index based upon those outcome measures, as shown here. And this also gets rolled up into a Hearts Performance Index. Again, one number that allows us to trend performance over time and to compare health systems and clinics as well too. Now, I want to show a practical real-world example of how this implementation of key drivers can be so successful. And this was shown beautifully out of a system in Chile and published in the PAHO journal just a few months ago. So this was a great example of implementation of one key driver and seeing what that impact could be. So in this case, the key driver was use of a standardized and simplified medication protocol. That standardized protocol was initiated immediately after hypertension diagnosis and included at least 2 blood pressure medications from the beginning, ideally in a single pill. That was the standardized protocol, and that was compared to the usual protocol, which was the national protocol at the time. And the outcome measures for this study were quite simple. Did patients adhere to treatment, and did they achieve blood pressure control at 1 year? And what was shown very powerfully in this study was that in about 1,500 patients treated in several clinics here at 1 year of follow-up, those patients who received the standardized and simplified protocol had a dramatically increased proportion of blood pressure control, 65% versus about 40%, and were much more likely to adhere to treatment, 70% versus 20%. So identification of one key driver, implementing that one key driver led to a dramatic increase in blood pressure control. Now, to further assist with implementation of these key drivers, Hearts has come up with a hypertension clinical pathway, as shown on this slide here. So what's nice about this is that all the information that's relevant to healthcare teams gets put on a one-pager. You see the medication protocol in the middle, which is the backbone of the Hearts program, but you see all of the other important characteristics of your healthcare system, which include all these key drivers: how to accurately measure blood pressure, how to cardiovascular risk assess your patient, how quickly to bring your patients back in, what your goals of treatment should be, etc. So everything included on one page. These can get posted in your clinics and your health systems and are a nice reminder for providers and nurses for what we need to accomplish. Hearts has also produced a number of educational modules, which we think facilitate the understanding of the work of key drivers. These can be accessed in PAHO's virtual campus. They're available in both Spanish and English, and they go into much greater detail about all of the drivers that we've talked about, and we highly encourage you to access this educational material if you can. So let's finish up talking briefly about some of the challenges and learnings we've had over the last year or two. Let's start with challenges. Number one, first and foremost, you can imagine healthcare systems in the Americas have quite a bit of variability in their use of electronic health records, from fully electronic to hybrid systems to paper. And that variation creates some challenges in data acquisition. There's also quite a bit of variation in quality improvement infrastructure. And of course, these two go hand in hand. If you have difficulty obtaining data, then you have difficulty creating a quality improvement infrastructure. There's also interest in working in perhaps other areas that aren't covered by the key drivers. So as an example, why don't we just spend more time and energy on lifestyle? And our response to that is lifestyle is critical, but while you're working on lifestyle, implement the key drivers that the literature has shown to be effective, and you'll see improvements in your control rate. And then, of course, cost and staffing, specifically for generating the data and providing reports to frontline physicians. And here are some of the lessons we've learned. 17 recommendations is a lot, we understand that, but start with what's currently feasible in your healthcare system. So pick a few agreed upon key drivers that we know are critical. Measure your blood pressure accurately. Use a standardized protocol with a fixed dose combination pill and bring the patient back quicker. Those are three very straightforward key drivers that we know will improve the blood pressure in your system. Begin to build your QI infrastructure using whatever data you have. So if you don't have an electronic record, begin to use paper charts. Look at 5 to 10 paper charts a month and begin to create data that can be then given to your frontline physicians to improve their performance. And importantly, produce this data frequently. We think monthly is best, and drill it down to the level of the clinic, individual provider, and nurse, and you'll see that your control rates will begin to increase. So in conclusion, we think that to improve blood pressure control, we must identify those key drivers of blood pressure control. We then need to translate those drivers into process measures and to use those process measures in a robust performance feedback system to your individual frontline clinicians and clinics. Key drivers are evidence-based, they're guideline supported, and the identification of these key drivers and process measures is not just an academic exercise, but we feel that these are practical and essential tools for primary health clinics and systems to improve their blood pressure control rates. And with that, I will conclude and thank you for your attention, and we hope that you found this information helpful. Thank you.